we will move on to the next talk. It will be by Dr. Sanjay Wadhwa on locomotor disability evaluation.
Good morning, everyone. Before I make a presentation on my topic, I would like to congratulate Professor Using sir. Always brilliant, always excellent, and even at this age, there is always something to learn from sir's presentation. His presentation is very methodical, systematic, and we remember him very fondly as an excellent teacher. He has been my predecessor in the department. Thank you so much, sir. I can guarantee any student who follows this kind of presentation and preparation, I guarantee will pass 100%. It will take a lot of effort on the part of the examiner to fail that student, and if it happens, the examiner must have been extremely biased. So, thank you, and I begin my presentation on a topic which is very dear to me. I will be covering the locomotor disability evaluation, and a disclaimer in the beginning itself that this presentation is based entirely on the Gazette of India notification dated 12th of March 2024, issued by the Department of Empowerment of Persons with Disabilities, Ministry of Social Justice and Empowerment. Because when it is a question of guidelines for assessment, the disability certificate is a very important legal document. We cannot have our own format or ideas. We are bound by certain guidelines which have been highly respected and outcome of a lot of hard work. So you will all be very safe if you stick to the guidelines. There are a few comments and concerns at the beginning itself I want to express. There are no perfect guidelines anywhere in the world. I had access to some of the guidelines from the developed countries. There are none which are, they are always under revision. It is a work in process. In India, there is a history to the guidelines in disability assessment, which started way back in 1981 when the International Year of Persons with Disabilities was observed. AIMS took a lead in that, and in 1985-86 held a national level seminar. Recently, since the launch of the revised guidelines in March 2024, there have been 8 training programs organized by the Department of Empowerment of Persons with Disabilities, and more than 6,000 doctors are claimed to have been trained in these programs. A few comments and suggestions have been received as a result of the training programs, and these are being assessed, analyzed, and an amendment to the existing guidelines may soon be issued by the Department of Empowerment. But let me express that disability is an experience of the whole person and not of an organ, part, limb, region or system. So these are some of the concerns about the locomotor disability guidelines, and whenever I have the chance to interact with international experts, they always say, Dr. Wadhwa, your guidelines are good, but they are lagging this particular concern. They don't reflect disability in relation to the whole person. Let us also listen to the courts, because many times when I appear in the motor vehicle accident claim tribunals in the courts, the honorable judge asks that this person has produced a disability certificate which says so many percentage of disability in relation to his left lower limb. But in order to award a compensation to the person, we need to reflect in relation to the whole person, because there are certain guidelines which the judges refer to when awarding the quantum of compensation. So we can always move in that direction, and there is a wonderful ICF model of disability in our field. It expresses everything so beautifully. Unfortunately, we are very slow to adapt to it, and much slower in putting it into our day-to-day practice. So the content is arranged in this way that the guidelines related to disability assessment are divided into various sections. It is a very voluminous document. The Hindi and English version combined has more than 850 pages. Section A deals with extremities, upper and lower extremities, which are page number 456 to 461. I am referring to the English language section of the guidelines. The spine deals with subsequent 5 pages, 461 to 465, etc. So it goes on, and other than these sections from A to K, there are certain other pages also. For example, page 456 to 482 deal with other things such as chronic neurological conditions, blood disorders, and multiple disabilities. And why I am mentioning these three is because there is an element of locomotor disability component in these areas also. For example, a person suffering with blood disorders may have bleeding into the joint or into the brain, and as a result may have locomotor disability. Multiple disabilities have more than one type of disability, and sometimes, and rather most frequently, locomotor disability is one component. Along with that, there may be mental retardation, there may be visual impairment, hearing related disability, etc. Then there are certain appendices as a part of the guidelines. Appendix 1, 2 and 3. These are from page 524 to 530. This is the facsimile of the Gazette notification. It mentions the date 12th of March 2024. It is freely available in the public domain. If you Google it, you will get the entire document. I will focus to the area which is related to my specialty and the topic of presentation today. It is locomotor disability. Now, it is section A. It defines locomotor disability that a person's inability to execute distinctive activities associated with movement of self and objects resulting from affliction of musculoskeletal, nervous system or both. So in your day-to-day practice, in your disability assessment clinics, you will come across people who are having either poliomyelitis, amputation, stroke, nerve injuries, injuries to the bones and joints, post-fracture sequelae, stiffness of the joints, and Hansen's disease, acid attack victims, muscular dystrophies, dwarfism, etc. So, locomotor disability is section A under a bigger group which is physical disability. Under locomotor disability, there is leprosy cured person, there is cerebral palsy, there is dwarfism, muscular dystrophy and acid attack victims. So you must know all about these, and these conditions are defined, and in subsequent pages there are guidelines how to assess and certify a person if the person is presenting with any of these, which are under the umbrella of locomotor disability. So there are further details of each one of these things. Time will not permit me to go into these things because I will welcome at the end of my presentation certain questions and comments. But you must be familiar with these guidelines because this is one particular area which will distinguish you from other medical experts and specialists. It is normally expected that the core concept in PMR is disability, its assessment, certification and training the person back to the maximum possible functioning, taking into account the activities of daily living. Other specialists will not be able to assess the ADL status of an individual, but PMR experts are unique that it is an integral part of their training. So section A has 1.1 which deals with guidelines for evaluation of permanent physical impairment of upper extremities, and there are certain components. These relate to various assessment of coordinated activities, assessment. Then this is one important formula which you will notice repeatedly occurring in the guidelines. This is known as the combination formula, A plus B within bracket 90 minus A divided by 90, where A is the higher value and B is the lower value. In the entire guidelines related to the disability assessment, there are multiple places where there is a need to use this formula. Many a times, the addition of two components is not simple arithmetic addition. So you have to use this. This is also known as telescopic combination formula and by a few other names. Now in the entire locomotor disability section, the formula that is used is A plus B 90 minus A divided by 90. But if you look at the multiple disability section of the guidelines, the 90 will be replaced by 100. So there is a hand component in the upper extremity where you take recourse to assessment of prehension, because prehension is very important function of the upper extremities. So there is a different weightage given to different fingers and different types of grasps, depending upon their importance in day-to-day activities. Then there is a set of principles for evaluation of sensations, because many people with locomotor disability may have partial or total loss of sensations. Then there are assessment of muscle strength, especially in lower motor neuron diseases such as poliomyelitis or diseases of muscles. So muscle strength assessment as per the MRC scale is very important, and a certain grade of muscle strength has a corresponding percentage assigned. Stability component is very important. Then there are certain extra points which are over and above the assessment findings of loss of sensation, loss of muscle strength, etc. So in the extra points we pay attention to shortening. First half an inch there is no additional weightage. Every half an inch beyond the first half inch 4% additional weightage. Maximum extra points for associated problems are 10%, which excludes shortening. Deformity, pain, loss of sensation, complications, these are some of the areas of extra points. Then there is section B. Section B deals with guidelines for evaluation of permanent physical impairment of the spine. Section A was related to the extremities. Spine has certain conditions with which people present to us, and these conditions can be traumatic lesions or non-traumatic lesions. I hope I am making some sense. Those of you who are a part of the disability assessment clinic, they are working up the cases and presenting to senior residents and the faculty members, would be familiar with these things. How many of you are familiar with the guidelines? Please raise your hand so that I have an idea. I think almost 75% of the people are familiar with these guidelines. So this is good, but then everybody should be familiar. I expected only the resident doctors to raise the hands. I know faculty members are familiar. So in certain areas of the injuries to the spine as a result of a traumatic episode, cervical spine injuries are also given certain weightage. Then depending upon the intervertebral disc lesions, thoracic and thoracolumbar spine regions, lumbar and lumbosacral regions of the spine, if there are fractures or involvement of intervertebral disc or there is displacement, there are certain percentages. You cannot afford to be arbitrary and assign whatever percentage. There is a definite element of exaggeration of symptoms when people want to derive extra benefit. So you should be aware that this is possible. You must know how to differentiate between the actual symptoms and their severity versus exaggeration of symptoms. Whenever you are in doubt, always consult your seniors. Then there are certain people who can show you the MRI film and that will be reported as having a lesion of the intervertebral disc. You must always correlate and fact check whether it is just an incidental finding or there are associated symptoms because of that which are contributing to the disability in the day-to-day experience of the person. Non-traumatic lesions may more often happen in the PMR setups, and these are scoliosis and or kyphoscoliosis. The standard recommended method of assessment of the angle is Cobb's method. You should all be familiar with the correct method of getting the person x-rayed and then calculating the Cobb's angle, because percentage of impairment assigned depends upon the degree of the Cobb's angle. Between 0 and 10 degrees, any deviation is considered as postural asymmetry, and a curve which is more than 10% is considered scoliosis. And depending upon the Cobb's angle, the scoliosis group of patients are divided into various groups, group 1 to 7, and percentage of impairment assigned is depending upon that. It is also important that a person with scoliosis or kyphoscoliosis should also be assessed for cardiopulmonary limitations if present. Additional weightage in percentage of permanent impairment is to be given according to the severity of involvement. In cases of scoliosis of severe type, cardiopulmonary function test also may be required. There are certain quick and reasonably correct, accurate methods of bedside assessment of the involvement of cardiopulmonary function. And one of them is measurement of chest expansion. The other is single breath count. So according to how much is the maximum chest expansion, there is certain percentage of permanent physical impairment assigned. Depending upon what is the single breath count, there is again a certain percentage of physical impairment which is assigned. So just be familiar with this thing and try to put it into practice. You may not get such cases very often, but whenever you get, you should not be looking very ignorant. What is this? हमने तो कभी देखा नहीं, हमने तो कभी सुना नहीं, like that. And as I told earlier that this is a very important formula which keeps recurring in the guidelines, A plus B 90 minus A divided by 90. Once I got a call from the Directorate General of Health Services. A person had obtained a disability percentage certificate from some other hospital, and there the person had added A and B together and then within bracket 90 minus A and the entire figure divided by 90. So depending upon how you understand and interpret, blunders can happen. So if you look closely, if there are two components, the final computed percentage of disability will always be higher than A, which is higher value. But if you use A and B both together and add and then divide by 90, it will be much less than B also. So please be alert. Don't rush through. Doctors are notorious. इनका mathematics बहुत weak होता है. Don't let that impression persist. Mathematics weak नहीं होता doctors का. It is just that they are bogged down by so many other issues and concerns. So any slight oversight or negligence on part of the assessment members can lead to unnecessary ridicule. Then there are certain other situations also in locomotor disability. Imbalance of the torso. How much is the imbalance depending upon that? What is that? Plumb line is a very simple system tool other than measuring tape, goniometers, etc. So depending upon how much is the deviation from the plumb line, vertical, then there are certain other situations. Pain is very common symptom in locomotor disability group, but it is difficult to quantify in a day-to-day practice. Depending upon what is the complaint expressed by the patient, how much is the involvement or impairment of activities of daily living, and supported by an evidence how much is the requirement of analgesics by the individual, you can come to some conclusion. You can use visual analog scale to be a little more objective. Otherwise, people can exaggerate. I am not able to sit, I am not able to sleep, I am always tossing and turning because of the severity of pain. So that is why there is a cap to the percentage of weightage given to pain, because people can exaggerate. Leg length discrepancy is another common finding in locomotor disability area. So depending upon how much is the leg length discrepancy, additional weightage is given. For first half an inch shortening, there is no additional weightage. But for every subsequent half an inch beyond that, 4% additional weightage is given to the person's permanent physical impairment. Then there are certain neurological deficits also which may be part of the presentation. These are the kyphotic angle deformities. Earlier we had discussed the scoliosis. So depending upon what is the degree of deviation, and these are according to the Scoliosis Research Society's recommendations regarding degree of abnormal curvature. Less than 40 degrees of kyphotic curve, there is no additional weightage given. For 41 degrees and beyond, greater the kyphotic angle, greater is the percentage of permanent physical impairment. This I have already covered partially in the earlier segment. There are certain miscellaneous conditions associated with disorders of the spine, subjective symptoms of pain, no involuntary muscle spasm, not substantiated by demonstrable structural pathology, there is no additional weightage. Pain, persistent muscle spasm and stiffness of spine, substantiated by mild radiological changes and regular need for treatment such as medications and non-pharmacological measures, up to 20% additional weightage is assigned. And the important word is up to. You don't have to give additional 20% to everybody. Then subsequently, depending upon the further severity, higher and higher weightage is given. Then coming to section C. I am rushing through because otherwise it is not possible to touch different other sections which are equally important. Section C deals with guidelines for evaluation of permanent physical impairment in persons with amputation. This is very important. Every day PMR department is attending to persons with amputations and they are candidates for disability certificate and subsequent benefits arising out of that. In cases of multiple amputees, which may sometimes happen, the percentage of permanent impairment is to be computed by using the combining formula. For example, one lower limb may be amputated at a certain level. In the same individual, one upper limb may be amputated, or it may be the lower limb on the other side. So depending upon what is the higher value, what is the lower value, you can apply this combination formula. Then if the stump is unfit for satisfactorily fitting the processes, an additional weightage of 5% should be added to the value. Any complication in the form of stiffness of the proximal joint, neuroma, infection, etc. should be given up to a total of 10% additional weightage. Involvement of the dominant upper limb, most of the times it is the right upper limb in majority of individuals, in acquired amputation should be given additional 10% weightage, because dominant upper extremity is very important in day-to-day functioning. People sometimes make a mistake when it is non-dominant involvement, then also they try to add. Many a times you will come across people who have about 30% disability as per the guidelines. So in your hurry and worry to help the person, because 40% disability is the benchmark disability, you wrongly add 10% even if it is a non-dominant upper extremity involvement in acquired condition. And I have seen 2 certificates in which people with congenital malformations were also given 10% additional weightage. So please don't make these 2 common mistakes. Depending upon the level of amputation, if certain percentage of permanent physical impairment is assigned, more proximal the level of lesion, higher is the percentage, as is naturally expected. 100% permanent physical impairment for 4/4 amputation in upper limbs, and correspondingly in the lower limbs also there are corresponding percentages. For example, if it is a hind quarter amputation in lower limb, 100%. And as you go more and more distal, the percentage of permanent impairment goes down. There is no need to remember these percentages, because if you try to remember and mug up, you are more likely to make a mistake. So my humble suggestion is always keep a printout of the guidelines related to locomotor disability in your disability board, or at least have the soft copy in your smartphones. You can always refer to those. Don't try to remember and recall. There are many other things more important to remember. In congenital deficiencies, there is a separate section C dealing with this. Levels are more or less corresponding, whether it is a transverse deficiency, and there is some difference in the longitudinal deficiencies. Section D deals with guidelines for evaluation of permanent physical impairment in persons with clubfoot and a few other locomotor conditions. Clubfoot, then there are other conditions such as lymphedema, Charcot's joint. So you should be familiar, less frequently, but sometimes yes, you may come across people who are presenting with these conditions. Clubfoot is relatively more common than lymphedema or Charcot's joint in many PMR settings. Section E deals with guidelines for evaluation of locomotor disability due to chronic neurological conditions. In chronic neurological conditions, what is mentioned in the guidelines is those conditions which are stroke, and in stroke, the modified Rankin scale is recommended for use. Depending upon what is the MRS score, a percentage of permanent physical impairment is assigned. Then the other condition is Parkinsonism. Next condition is sensory deficits, whether it is anesthesia, hypoesthesia or paresthesias, because sometimes these can be more disabling than weakness or paralysis. Then neurogenic bladder involvement is another disabling finding. Depending upon what is the extent of bladder function deficit, percentage of permanent physical impairment is assigned. Section F deals with spinal cord injuries, a relatively common condition presenting in PMR departments. So depending upon the level of lesion as per the international system of classification of spinal cord injuries and their evaluation and use of Asia impairment scale, we assign certain percentage of disability. Bladder dysfunction is mentioned here also. In a person with tetraplegia, when the neurological level is C5 or above, up to 90% permanent physical impairment can be assigned. When the neurological level is C6 or below, up to 80%. Depending upon paraplegia level of lesion, when the lesion is T6 or above, up to 70%. Neurological level between T7 and T10, up to 65%. Try not to be arbitrary when there are guidelines in front of you. But these things are to be certified once the clinical condition of the patient has stabilized. It is not soon after the spinal cord injury that you start certifying the person. If there is chordoequina syndrome, up to 40% of disability when it is without bladder or bowel dysfunction. And if it is with bladder bowel dysfunction, then up to 60%. Section G deals with acid attack victims, less frequently seen in PMR settings, but sometimes they are there. That is why they are part of the guidelines. So depending upon the area of involvement of the skin and the depth of involvement, there is a certain percentage of impairment assigned. And there is a table starting from the scalp downwards, different parts of the body affected, and percentage of permanent physical impairment given. Total percentage of impairment in none of the cases will ever exceed 100%. Section H deals with cerebral palsy affected persons with disabilities, and there are two scales which are recommended: gross motor function classification system, GMFCS, and for the upper limb there is a different scale. So depending upon what is the level of GMFCS classification, for the upper extremity is a manual ability classification system. Depending upon the level, a percentage of disability is assigned. See, the condition of the person dictates what is the percentage of disability. And in many situations, when the condition is likely to change rapidly, reassessment is recommended. And this very often happens in muscular dystrophies. Section I deals with leprosy cured persons with disabilities. So depending upon the WHO's grading system, which involves eyes, hands and feet, a certain score is assigned, and based upon that grade, percentage of disability is computed. Again, in this situation also, involvement of the dominant upper extremity fetches additional 10% weightage. Section J deals with guidelines for evaluation of persons with short stature or dwarfism. Here, the cutoff height is 147 centimeters, that is 4 feet and 10 inches, regardless of gender. Depending upon how much is the further reduction of the vertical height in the adult person, a percentage of disability is assigned. So as a matter of reference, we are many a times concerned with the benchmark disability from where the benefits start, 40%. So a person with a vertical height of 4 feet qualifies for that 40% disability. Section K deals with muscular dystrophy, which I mentioned is again an important condition, in which the condition may change towards the worsening side with the passage of time. So reassessment may be required, but in order to reduce the bothering of the patient and family and to reduce the burden on the healthcare team, generally recommendation is don't recommend review before less than 5 years have passed. What is the medical authority to certify locomotor disability? That is also mentioned. So while constituting a board, these are the things to be kept in mind. Then common instruments required for certification of locomotor disability. See, let me tell you, MRI scans, CT scans are not required. The common things which are required are those which are available freely in the OPD settings. These include a measuring tape for measuring the vertical height of the person, degree of chest expansion, shortening of an extremity, or difference in the girth of a limb. Goniometers, small, medium and large depending upon the joint affected. Handheld dynamometer, a clean cotton piece for testing the corneal sensations. A ballpoint pen for testing sensory deficits, for example in leprosy cured individuals. And X-ray examinations in cases of spinal deformity, amputation, clubfoot, congenital deficiencies, fractures, arthritis, etc. So these are some of the appendices in addition to what are the sections. Appendix 1 deals with MRC scale for muscle strength assessment. Appendix 2 has Form A and Form B. A for assessment of upper extremities, B for lower extremities. Appendix 3 is average normal range of motion across different joints, and these are given as part of the guidelines. So this is where I will like to conclude my presentation on the locomotor disability assessment, which is very important for PMR trainees and experts alike. If there are queries, because time will not permit, you may note down my email ID or you can ask from the organizers, and you can keep in touch with me during those. Stability component for the lower limbs and coordinated activities for the upper limb are important. And this is the committee which was constituted by the Government of India for framing the guidelines, and I had the honor of chairing this. Thank you.
Thank you, Professor Wadhwa. As Dr. Wadhwa said, please contact him if you have any questions. We have also shared the Excel formula in your WhatsApp group. I would like to invite Dr. K. Matthews to present the memento to Dr. Wadhwa.